What's up, Ninja Nerds? In this video today, we're going to be talking about aortic valve disease that includes aortic valve stenosis and aortic regurgitation. Before we get started, if you guys like this video, you benefit from it, it makes sense, please support us. And the best way that you can do that is by hitting that like button, commenting down in the comment section, and please subscribe. Also, down in the description box below, I have a link to our website where you guys can check out our awesome notes, illustrations, follow along during this video to truly get it all down pat. All right, let's get started. With aortic valve disease, there's two types, aortic stenosis, aortic regurgitation. Let's talk about the basic definitions about what the cause is and what's the problematic issue from that disease. So in aortic stenosis, the primary point behind this issue here is that the actual aortic semilunar valve, which is the valve that's designed to be able to prevent one-way flow and prevent backflow, going from the left ventricle, we want blood to go into the aorta, and we don't want it to go back, right? In a patient who has aortic stenosis, this aortic valve is very fibrotic. It's calcified, it's sclerotic, and it doesn't want to open very well, okay? So in aortic stenosis, the patient's aortic semilunar valve is very fibrotic, or it's calcified. And because of this, it makes it difficult to open, and it makes it difficult for blood to be able to go from the left ventricle into the aorta during what phase of the cardiac cycle? Well, what is the phase of the cycle when the ventricles are contracting? This is called systole. So this is during systole that you would actually have this murmur occurring. So this issue here is a systolic process, it's a systolic murmur that occurs when there is difficulty being able to get blood from the left ventricle into the aorta. It's very difficult, okay? In contrast, a patient who has something called aortic regurgitation. What happens in aortic regurgitation? In aortic regurgitation, this valve, the aortic semilunar valve, is not giving a good seal. And the purpose of this valve is to prevent backflow. But guess what? Blood that's in the aorta during diastole can flood back into the left ventricle because this valve isn't giving a good seal. So in aortic regurgitation, there is a poor seal of the aortic valve. And in that situation, it causes blood to go from the aorta to the left ventricle. And in what phase would this be occurring? Well, it's when the phase of the diastole. It's when the ventricles are supposed to be relaxing. Blood isn't supposed to be coming from the aorta. It's supposed to be coming from the left atrium. And so in this situation of diastole is when we see this issue and this problematic murmur during aortic regurgitation. All right, so aortic stenosis, fibrotic, calcified valve, doesn't allow for blood to easily go from the left ventricle to the aorta, during systole. Aortic regurgitation, it's a poorly sealed aortic valve that is causing a backflow or regurgitation of blood from the aorta into the left ventricle during diastole. Now the question is, what is causing this fibrosis and calcification of the aortic semilunar valve? And then what is causing this poor seal of the aortic valve and aortic regurgitation? Let's talk about that. So in aortic stenosis, one of the particular causes that you can see, there's a disease called rheumatic heart disease. It's secondary to rheumatic fever. You know, in a patient who ends up with what's called group A streptococcus beta hemolyticus infection, strep throat. They end up getting strep throat, they have their immune system respond to that bacteria, produce antibodies against it. And unfortunately, those antibodies attack other tissues like the valves. They love to attack the mitral valves and they love to attack the aortic valves. And when these antibodies attack the aortic valves, they cause inflammation and fibrosis of those valves. So in a patient who has what's called rheumatic heart disease, you can see this, they can have primarily two valves involved. Aortic valves and mitral valves. And what happens is this can cause aortic stenosis, and guess what? It can also cause aortic regurgitation. It can cause mitral stenosis, and it can cause mitral regurgitation. But the big thing to remember in rheumatic heart disease is it's an autoimmune destruction of the mitral and aortic valves. In this situation, it's the aortic valve. It causes fibrosis and stiffening and narrowing of the actual aortic valve. That is the big issue here. Okay, the next thing, when you think about a patient who has aortic stenosis and it's not rheumatic heart disease, you have to ask yourself the question, how old are they? If they're less than 70 years of age, it's likely something that was a congenital cause. And this congenital cause, most commonly when less than 70, is called a bicuspid aortic valve. Okay? It's often referred to as a bicuspid aortic valve. Now, generally the aortic valve is 3 leaflets. But during the embryological process, for some odd reason, here's your 3 leaflets, you decided I'm going to fuse these leaflets. And so now it looks like this. Now you got these leaflets all fused up right here. So now you have this like one completely fused leaflet here and then another one. So that's a bicuspid aortic valve. What's the problematic issue with this bicuspid aortic valve? It's super susceptible to calcifications for some reason. It's just super susceptible. And so because now it has this bicuspid valve, you can actually cause lots of calcifications to occur on this valve, which makes it more calcified, less pliable, less willing to open, and allow for blood to go from the left ventricle into the aorta. Boom, shakalaka, we done figured that out. So bicuspid aortic valve usually is a congenital problem, but doesn't become evident until a little bit later in life, and they're super susceptible to calcifications. In patients greater than 70 years of age, it's likely just old age and causing calcifications of those actual vessels. Of this aortic valve. In this situation, we call this dystrophic calcification of the aortic valve. So what is this called? In greater than 70, it's called dystrophic calcification of the aortic valve. In this situation, there's particular risk factors that not only cause calcifications, but almost, in patients who develop atherosclerosis, they develop plaques within their vessel wall. Think about dystrophic calcification that occurs on the aortic valves, similar to atherosclerosis. So what are the risk factors for patients who have atherosclerosis? One of the big things is hypertension. So hypertension, hyperlipidemia, any kind of like smoker, these patients are kind of in the high risk category. And when you have hypertension, hyperlipidemia, smoking, patients who are diabetics, they are kind of high risk, and then they can develop these similar types of atheromatous plaques that occur on these actual valves. So you start kind of getting like these atheromatous plaques. And as you get a lot of this atheromatous plaques around this area, they also accumulate a lot of fibrosis. So you get all these atheromatous plaques. On top of that, you get additional calcifications that are added on top of this. And this just causes the valve to become very stiff, very fibrotic, and decrease the amount of blood that can go from the left ventricle into the aorta. So all of these things happen. Again, what are the two big ones that I want you to remember? Don't forget rheumatic heart disease. And then think about age. Less than 70, bicuspid aortic valve. Greater than 70, dystrophic calcification. Really, it's just thinking atheromatous plaques on the valve. That's really all it is. And if these things happen, the left ventricle isn't able to pump as much blood as it wants through that narrow area and get it into the aorta. So this process is reduced. That's the problematic issue here. Okay, that's aortic stenosis. Let's now talk about aortic regurgitation. All right, so the next thing is aortic regurgitation. The problem is, again, blood backflowing from the aorta into the ventricles, particularly left ventricle, during ventricular diastole. What can cause this? Let's think about it. Here's your aortic valve, right? And so we're just taking a chunk of the aorta. So we're taking the ascending aorta and the aortic arch here, right? So this is just the ascending aorta and the aortic arch. Right here at the ascending aorta, here's your aortic valves, right? It's also connected to kind of like a little connective tissue that kind of anchors the valves there, okay? Now, anything that causes the aorta to become dilated, anything that causes the aorta to become dilated, so anything that can increase the risk of aortic aneurysms, would increase the actual problematic issues, because here's why. Imagine here, in this patient, I try to stretch or dilate this ascending aorta. I try to dilate the ascending aorta. And I try to, when I do this dilation of the ascending aorta, so I'm going to dilate the aortic root. When I do that, I pull apart the actual leaflets of the aortic semilunar valve. The farther they are away from one another, whenever they're supposed to close, they're not going to completely close, and blood's going to shoot back from the, what? Aorta into the left ventricle, especially during diastole. What are things that cause dilation of the aortic root? Think about it. Aortic aneurysms, right? Aortic aneurysms are a huge one. And there's so many things that can actually cause aortic aneurysms. One of them is think about particular types of connective tissue diseases. Well, first off, actually, what can lead to, what's the most common cause of these? Hypertension, right? Hypertension is a very strong risk factor for aortic aneurysms. The other one that you want to be thinking about is connective tissue diseases. So these you want to be thinking about things like Marfan or Ehlers-Danlos syndrome. The other thing that you want to think about is there any inflammation of the aorta? You know, inflammation of the aorta, it can actually cause a lot of sometimes medial cystic necrosis of the walls there, making them less actually strong and easy to be able to cause particular aneurysms and dilation and stretching of the actual aorta. So we want to think about things that can cause inflammation of the aorta. So we call this aortitis. And this will be a couple different things. So any kind of vasculitis can do this. What's called giant cell arteritis, another condition called Takayasu's arteritis. The other thing that you want to think about, a big one here, is called syphilis. So technically when someone has tertiary syphilis. Another thing to think about is particular what's called HLE B27 haplotypes. You know, there's conditions called ankylosing spondylitis and reactive arthritis. So we'll put ankylosing spondylitis and something called Reiter syndrome or reactive arthritis. In these situations, they also have inflammation of the aorta. So anything that can really increase the actual risk of forming aortic aneurysms, it could be hypertension due to a lot of shear stress on those walls and dilating them, connective tissue diseases, which is actually weakening the connective tissue layers, particularly the elastic laminas and the externa, causing them to balloon up, or inflammation of the aorta that causes inflammation, destruction of the actual walls of the vessel, weakening the vessel and increasing the risk of them actually dilating. All of these things dilate and pull the actual leaflets farther away from one another. There's one more particular cause. This one's a nasty one too. You know, if someone has a dissection, so let's say here blood is supposed to run up from the left ventricle, run through the valve into the aorta. But because of hypertension, hyperlipidemia, smoking, all of those things, there's weakening of the vessel. When the vessel is weak, you can actually dissect blood through the tunica intima, and it can dissect through the tunica intima and the tunica media. And this can go anterograde or retrograde back to the root of the aorta. When it goes back to the root of the aorta and starts compressing on this connective tissue area that holds that leaflet still, guess what it's going to do? It's going to compress on it, and you're going to lose this actual kind of imagine the thing that's kind of holding that actual valve up. I'm pressing on it now, it might lose that ability to stay where it's supposed to and kind of fall down. And now look, the leaflet may look something like this now. Now it's looking like this. And there's no way that that dang leaflet's going to connect with that leaflet during the ventricular diastole process. And blood can shoot right back down during diastole. So aortic dissections can definitely be a problematic issue as well. So one of them that I need you guys to remember is anything that can increase the risk of aortic aneurysms. And the second thing to think about is aortic dissection. These are the things to be thinking about. All right, beautiful. These are aortic root diseases. So anything that dilates the aorta, which would be aortic aneurysm, or dissects and actually compresses on the connective tissue that actually anchors those valve leaflets there, such as aortic dissection. Now, what about there's actual problems where there's destruction of the valve or issues with the valve not forming a tight seal as well, because it's not due to the aorta spreading it and actually distending or dilating or causing compression of the connective tissue that anchors the leaflet. What if there's actually destruction of the leaflet? Or there's inflammation of the leaflets so much that they don't want to come together because they're so rigid and not very pliable that when you want them to close, they don't actually move at all because they're so stiff and tight. And because they don't actually close all the way, there's not a good seal, blood can shoot right back in. So what are things that actually can cause a lot of fibrosis and calcifications over time in severe states where the dang valves don't even want to move anymore and come together? It could be, again, my friends, rheumatic heart disease, because again, you can see this in aortic stenosis and aortic regurgitation. You can see this in mitral stenosis and mitral regurgitation. The other one, less than 70, what was the cause, particularly for aortic stenosis? Bicuspid aortic valve. With patients who have bicuspid aortic valve. So there's a fusion of 2 out of the 3 leaflets that are fused now, and you only have this one cusp and this cusp. This is a bicuspid aortic valve. What are they predisposed to? Lots of calcifications. So this can actually calcify pretty readily. If it calcifies, that makes it less pliable, makes it more stiff, makes it less willing to close during the diastolic process and cause those valves to actually form a nice seal. So that's another cause. So a bicuspid aortic valve can actually do what? It can cause aortic stenosis and aortic regurgitation. Rheumatic heart disease can cause aortic stenosis and aortic regurgitation as well. The one though that is easy to remember, don't forget it, is there's bacteria here that are actually causing destructive lesions and actually destroying the valve. And now you don't have the actual complete length of the leaflet to coapt and connect with that one. This would be in conditions such as infective endocarditis. You know what else is interesting? Patients with bicuspid aortic valves are also at higher risk of infective endocarditis, but that's okay. Don't go too crazy. What I really want you to know though is aortic stenosis is fibrosis, calcifications of the valve. Rheumatic heart disease, bicuspid aortic valve, if they're less than 70, greater than 70, it's a calcification issue with atheromatous processes, patients who are hypertensive, hyperlipidemia, diabetic, they smoke, anything like that. If it's aortic regurg, the easy one to think about is there's aortic dilation, aortic aneurysms due to hypertension, connective tissue diseases, or inflammation, or aortic dissections that are actually pushing down on the connective tissue that anchors the valve cusp. Or there's actually disease of the valve cusps, and they're so fibrotic that they don't form a tight seal, rheumatic heart disease, bicuspid aortic valve, or you destroyed or eroded the valve away like an infective endocarditis. Now that we've done that, let's talk about the pathophys, the clinical features, the physical exam findings that we see in these aortic valve diseases. All right, so let's talk about aortic stenosis. Let's talk about the clinical features, physical exam findings, and the pathophysiology, right? So the classic features for a patient who has aortic stenosis, you guys want to remember how you remember the classic presentation? It's SAD. It's syncope, angina, and dyspnea. Those tend to be the most common clinical features. But what we have to understand is not just that they have syncope, angina, and dyspnea. These tend to occur on exertion particularly, but we should understand why these processes occur. Okay, so dyspnea, they tend to have shortness of breath or unpleasant sensation of the recognition of their breathing. Why? Okay. In a patient who has aortic stenosis, their valve is very, very fibrotic. Difficulty in being able to push blood out against that valve. So it has to exert higher pressure. So now if you're having to push higher amount of pressures to get blood through that small little opening because of the very fibrotic and stenotic valve, the pressures in your ventricles are going to start going up. So you know what happens? Because of this stenotic valve, the patient's left ventricle, they have a lot of high end diastolic pressures. And what happens is when the ventricles are under pressure, they thicken. They rise to the task. And they get jacked, they get yoked, and they start undergoing a process called hypertrophy, concentric hypertrophy, where they actually add their sarcomeres in parallel. So whenever the left ventricular end diastolic pressure goes up, it causes their left ventricles to get thick. And it causes left ventricular hypertrophy. So these puppies get real thick. And when they do that because now if it's thicker, you can generate more pressure to push blood out through the aorta, through that very pesky, fibrotic, calcified valve, okay? Here's the issue though. When someone has this high left ventricular end diastolic pressure and they undergo left ventricular hypertrophy, it decreases the size of this actual lumen and makes it more difficult for ventricular filling to occur. So with these two situations arising, this leads to a decrease in ventricular filling. Less blood is coming from the left atrium into the left ventricle now because the pressure in this area is just too high. There's too high pressure. Because of that, if the blood can't go from the left atrium into the left ventricle, it just goes into the next area of low resistance, which is in the pulmonary circulation. And so instead, this causes a backflow. And when it starts backflowing, it'll backflow into the pulmonary circulation and then induce pulmonary edema. Now, here's what happens. The pulmonary edema on itself can cause, actually dyspnea. But the pulmonary edema, we can actually cause them to have worsening dyspnea, even worsening dyspnea when they're exerting themselves. Why? You know, when you exert yourself, you actually increase, so this is one part, you increase your heart rate when you exert yourself. So this would be with exertion. When you increase your heart rate, what do you do to your diastolic filling process? When you work out and you exert yourself, your heart rate's faster. If you have a faster heart rate, your diastolic filling process is shorter. So it decreases the diastolic filling time. If you decrease the diastolic filling time, you're going to get less ventricular filling. If there's less ventricular filling on top of there already being due to high pressures, that's going to lead to even worse reduction of ventricular filling. It's going to lead to increased backflow and increased pulmonary edema. So this is where the problematic issue comes, is they may have some baseline pulmonary edema with not a ton of dyspnea, but then you have them exert themselves, increase their heart rate, reduce their diastolic filling time, less blood is actually going from the left atrium into the left ventricle, more of it's backing up into the pulmonary circulation and causing more pulmonary edema. That's definitely going to cause dyspnea on exertion. That should make sense. Okay, beautiful. What about angina? Angina is a sense of chest pain, and it's usually underlying due to ischemic type of chest pain. So what happens here? You know, in patients who have this left ventricular hypertrophy because of that high pressure that they're having to generate to push blood against that stenotic valve, when you cause this hypertrophy, these muscles, they're really big now, and they need more oxygen to be able to generate these high pressures to push blood out of the ventricle. So with the reward of left ventricular hypertrophy, with all that hypertrophy, you end up with a problem here. You have a high oxygen demand now. So now you have this high oxygen demand where you honestly, the demand is so high because these ventricular myocardial cells are much bigger and they need more oxygen to contract harder and generate more force to push more blood against that stenotic valve. Now, if that's the case and you have a higher demand, that would be a problem if there is a reduction in supply. So this is the issue. But is there another problematic issue where there is a reduction in supply? Yeah, guess what? Having this left ventricular hypertrophy, guess what happens here? You actually cause, whenever there's more hypertrophic muscles, there's actually vessels, your coronary vessels, they run here in like the epicardium, right? So here's you're going to be like a coronary vessel. Every time your actual muscles contract, they do squeeze a little bit on the coronary vessels. Now imagine you have a very thick ventricular myocardium. Every time it contracts, it's going to really squeeze on those coronary vessels and reduce the ability to supply blood to the myocardium during diastole. And so with this high ventricular hypertrophy, you can actually squeeze the coronary vessels. And if you squeeze the coronaries, you actually decrease the coronary blood flow. And if there's a combination of decreased oxygen supply because of less coronary flow, again, this is supplying oxygen-rich blood to the myocardium. If there's a reduction in flow and an increase in oxygen demand, there's a mismatch there, enough that it can cause ischemia to the muscle and cause angina, the chest pain. Here's another thing. You know what can make it worse? Exertion. Have them work out. If they're working out, they're going to increase their heart rate. So that's going to be the exertion factor, right? If they're exerting themselves, they're working harder. What does that do to the diastolic filling process? It decreases the diastolic filling time. Why is that a problem, my friends? When you decrease the diastolic filling time, that reduces the coronary flow. So, you know, whenever a coronary perfusion actually is occurring, it's occurring whenever there's ventricular diastole. So that's when the actual myocardium gets its blood, is during diastole. So if you reduce diastolic filling time, you reduce the coronary flow. And this problematic issue of having a reduction in coronary flow and an increase in oxygen demand is a recipe for angina. So again, the general concept is that when there is hypertrophy, your muscle cells are bigger, they're having to work harder, they need more oxygen. If you reduce the flow of actual oxygen to the myocardium by either squeezing the coronaries because they're big and bulky now, the muscle's big and bulky now and it's compressing them every time it contracts, or you're exerting yourself by increasing your heart rate, reducing your diastolic filling time, less coronary perfusion time, that is going to lead to a reduction in flow and an increase in demand, and that is going to lead to angina, particularly on exertion. Okay, let's now talk about syncope. All right, so next thing we have to think about is the syncope component of aortic stenosis. Now, when someone has syncope, what is the particular cause behind this? Well, there could be a lot of different reasons, but in this situation, what's really cool in this one is, again, you have a particular problematic issue. Again, we know that the left ventricle is hypertrophic, right? Because it's gonna have high left ventricular diastolic pressures, because it's having to push blood against a very rough and stenotic valve, so it has to generate these high pressures. So we know there's gonna be left ventricular hypertrophy. But no matter what, you're having difficulty in pushing blood from the left ventricle into the aorta, right? There is a reduction here potentially. Now here's the thing. It seems like it's a reduction, but it's actually a fixed cardiac output for the most part. So whenever there is this left ventricular hypertrophy, it actually maintains what's called a fixed cardiac output. Okay, there is a fixed cardiac output. Your left ventricle is exerting a maximum amount of pressure as it can to push as much of the blood in the ventricles out into the aorta, okay? Now here's the thing though, whenever you have this issue, it might not be a problem because if you're able to maintain a good enough cardiac output, you'll perfuse these vessels that actually go up and supply particularly the brain, right? So if I were to draw like a good old brain here, as long as I'm maintaining a good enough cardiac output that my mean arterial pressure is good, I'm gonna continue to keep perfusing the brain and cognitive function will stay intact. Now, it's when I have some other issue that is coinciding with this that causes maybe other things to get a little bit worse. Because you know what the thing is with cardiac output? Cardiac output influences what? It influences our mean arterial pressure. So we have this fixed cardiac output due to the aortic stenosis. Now, here's where it becomes an issue. And a patient who is exerting themselves, right? You know when you exert yourself, you work really hard, so you're exercising for some reason. When you're exercising, generally, when you exercise, your actual vessels, these vessels here that are going to those muscles, undergo vasodilation. So they undergo vasodilation. So whenever you exercise, you cause vasodilation of your blood vessels. Now when you vasodilate blood vessels, what does that do to the systemic vascular resistance? So what am I gonna do to the vascular resistance in these actual systemic vessels? I'm gonna drop it. So I'm gonna decrease my systemic vascular resistance. When I decrease systemic vascular resistance, what will that do to the mean arterial pressure? It'll drop it. If I have a fixed cardiac output, and that's just kind of just maintaining at least a normal map, a normal perfusion, on top of that, I'm exercising intensely, I'm vasodilating my vessels, I'm really dropping my systemic vascular resistance, I might drop the map enough even though I have a fixed cardiac output. That's enough that if I do drop my mean arterial pressure, I don't perfuse the brain enough. If I don't perfuse the brain enough, there's a decreased perfusion of the brain. It's enough that for a momentary time period, I could lead to a syncopal event. Okay, so that's the kind of theory behind this, is that you see this more particularly with exercise where they can have the syncopal event because they're working really hard. When they're working really hard, they're obviously sweating, they may get dehydrated. That will decrease their stroke volume and it could decrease their cardiac output. So that's another thought process to think about. But the other thing is that it's causing massive vasodilation of their vessels that are supplying those muscles, reducing their vascular resistance, potentially dropping their map. But again, don't forget about the other thing too, is that you could actually have some problems with the fixed cardiac output if you have them actually super dehydrated. So they're exerting themselves and they're causing themselves to become volume depleted. If they get dehydrated enough, it drops their stroke volume. That could actually drop their cardiac output and drop their map. Okay, but this is kind of the pathophysiology behind syncope. Now that we've covered that, we got dyspnea, we got angina, we got syncope down. The last one to think about here is thinking about some of the consequences of left ventricular hypertrophy besides the SAD symptoms. The other thing that you want to think about here is when the left ventricle is contracting, man, is it generating a lot of force. So this left ventricular hypertrophy is causing a very high force of contraction, right? It is going to really have to contract as hard as it can to generate these high pressures to push against that very stenotic aortic valve. And because of that, it'll produce a left ventricular heave. So we call this a left ventricular heave. You can literally feel the left ventricle contracting and slamming up against the chest wall when it contracts because it's trying to generate a lot of pressure. That's one thing. The other thing here, because of the left ventricular hypertrophy, is the pressure, right? So whenever you have left ventricular hypertrophy, the left ventricular end diastolic pressure is probably going to increase. When that happens, it causes there to be an increase in the left atrial pressure, right? Because the atria has to generate enough pressure to push the blood down into the ventricles, right? So whenever your end diastolic pressure in the ventricles go up, then the atria has to increase its pressure. So guess how it increases its pressure? It gets on steroids and starts working out and becomes hypertrophic. And when it becomes hypertrophic and super thick, it will contract really hard sometimes towards the late phases of diastole to squeeze as much blood as it can down into this rigid ventricle. And what is that called? So whenever the left atrial hypertrophy occurs, this will lead to another process. This will lead to what's called atrial hypertrophy. When the atria undergo hypertrophy, when it contracts, it generates something called an atrial kick. And that atrial kick, when it contracts and squeezes blood down into the ventricles and really hard against the ventricles during the late phase of diastole, you know what we call this? We call this an S4 heart sound. So these are things to remember. So you can have a patient with a very intense apex beat with a left ventricular heave because of this intense contraction, left ventricular hypertrophy, and an S4 heart sound in addition to that due to the atrial hypertrophy because of the high left-sided pressures. All right, we talked about these things now. So don't forget the SAD symptoms. Don't forget a lot of them occur particularly with exertion. Don't forget the S4 heart sound and the left ventricular heave. And now let's talk about aortic regurgitation. All right, so let's talk about aortic regurgitation now. So we'll go over everything that we did with aortic stenosis, right? So in a patient who has aortic regurgitation, it's important to remember aortic regurgitation can actually be kind of broken down into two components, an acute aortic regurgitation and then a chronic aortic regurgitation. For the acute aortic regurgitation, it's actually important to remember that some of these are very nasty causes that we can't forget. So what are some of those? Don't forget the ones such as infective endocarditis. This is definitely a big one. Infective endocarditis can definitely lead to acute aortic regurgitation because it's just destroying the valve. Other things is potentially acute rheumatic heart disease, but really it's a lot of those things, particularly like the aortic dissection. An aortic dissection would be an acute onset type of aortic regurgitation. So that's definitely one to remember, is again some type of aortic dissection. You know, these are the big things that you want to remember. Sometimes there, again, it could be like an acute rheumatic heart disease, but I think the big ones to remember is an acute aortic dissection and an infective endocarditis as being some of those that can really cause some problematic issues here. Now, if someone has an acute aortic regurgitation, what are the clinical features and what is the pathophysiology to explain it? It's really a cardiogenic shock is what it is. In a patient who has aortic regurgitation, when their left ventricle contracts, right, they're going to try to push blood into the aorta, right? And when they push blood into the aorta, the aortic valve is generally doing what? Preventing the backflow. But in this process, it's not doing a dang good job of it. And all the blood that we push into the aorta, some of it will actually continue through the aorta and into the systemic circulation. But guess what? Some of it will flood right back down into the ventricles. So when you think about that in a simple way. The stroke volume is the total volume of blood that's being ejected from the ventricles, right? And if I'm actually pumping blood out of the ventricle into the aorta and a bunch of it's pumping back down, that my stroke volume actually didn't really increase very much, did it? And so when you truly think about it, in these patients who have an acute aortic regurg, there is actually a decrease in the left ventricular stroke volume because you're pushing a good chunk of blood out, but a lot of it's coming back down. Like imagine 75% of it went out into the aorta and 25% of it flew back in. That's a reduction in your total stroke volume. If you reduce your left ventricular stroke volume, you reduce your left ventricular cardiac output. And that could potentially put you into a hypotensive situation. So it could actually drop your blood pressure and cause hypotension. Enough that this could put you in a state of shock, cardiogenic shock. And so this is an important thing to remember. What's another problem that comes here? Well, whenever your left ventricle contracts and pushes the blood out into the aorta, let's say a good chunk of it goes forward, but a good chunk of it floods back down into the left ventricle during diastole. Now, every single time, you think about it like this, every single time your left ventricle pushes blood out, you're bringing a good chunk of blood back down. And so you're getting all of this blood back from the aorta, and you're also supposed to be getting the blood from the left atrium coming from the pulmonary circulation. So all of this blood is just going to accumulate in your left ventricle. So now my left ventricle, when I'm in the relaxation stage, diastole, it's filled with blood. And so there is an increase in the left ventricular end diastolic volume. The volume of blood that's in the ventricle when it's resting, at the end of its resting phase. It's going to have tons of blood. Blood from the left atrium, blood that's coming back from the aorta, okay? If that's the case, what does that do? One of the things that it does is it causes that actual volume to start kind of going back into the left atria. Because you know, whenever you have high volumes, generally what you're designed to do is to increase the size of that cavity where the volume is so that you don't have high pressures. But in an acute situation, your ventricles don't have enough time to dilate, remodel, and accommodate these high volumes. And so because they do not dilate, so there's no remodeling that's occurring in these acute phases, you can't compensate. You can't dilate the ventricles to accommodate that volume. And so subsequently, the pressures go up. When the left ventricular end diastolic pressure goes up, your atria can't push blood into the left ventricle. And if you can't push blood into the left ventricle, now your left atrial pressures go up, and that causes the backflow of blood into the pulmonary circulation, and that leads to pulmonary edema. And this can present in a variety of ways: hypoxia, dyspnea on exertion, dyspnea at rest, paroxysmal nocturnal dyspnea, orthopnea, all of these different things. But when you see a patient who is in full-blown hypotensive cardiogenic shock and pulmonary edema, and they have infective endocarditis as a concern, aortic dissection as a concern, and you know that they have this blowing murmur now, think about an acute aortic regurg in this situation, okay? So that's acute aortic regurgitation. Again, cardiogenic shock, hypotension, pulmonary edema, and again, they're probably going to become reflexive in this way. Whenever you're hypotensive, one of the ways that you try to compensate is by increasing your heart rate. And so you may see these patients trying to get a little tachycardic to compensate for that. But in any way, nonetheless, big thing, cardiogenic shock, pulmonary edema. What about when they're in chronic aortic regurg? This is when the ventricles have time to remodel and to dilate to reduce those end diastolic pressures and accommodate all of that larger volumes. Let's see how they do that then. Now, in chronic aortic regurg in these patients, what happens is, again, you're going to have something very interesting occurring. They're going to have a very high left ventricular end diastolic volume because, again, the blood that they push out into the aorta, some of it goes out, but a good chunk comes back in, and the blood that's coming from the left atrium in combination is accumulating here. So their end diastolic volumes are going to be high. The way that you compensate for that is make room. And so you trigger left ventricular dilation. But remember, when you undergo left ventricular dilation due to volume overload, what type of hypertrophy is that? Because it's actually hypertrophy. You're making the muscle cells bigger, but you're making them bigger in length. This is called eccentric hypertrophy. What is this one called? Eccentric, in comparison to aortic stenosis, which was concentric hypertrophy. So you're making these actual muscle cells longer and making them thinner because you're adding the sarcomeres in series, whereas in the concentric hypertrophy and aortic stenosis, it was added in parallel. Now, when you have this left ventricular dilation, now you make the left ventricular cavity larger, so you allow more volume to be tolerated, so more volume in the left ventricle. If you can tolerate more volume in the left ventricle, Now you can actually lower your left ventricular end diastolic pressures. If you do that, you lower your left atrial pressures. And if you do that, you reduce the backflow. If you reduce the backflow, you reduce the pulmonary edema. Man, that's pretty cool, right? Here's what else. Guess what else, guys? That's one way that we try to allow for this situation in chronic aortic regurg. So what I'm trying to say is that we reduce the pulmonary edema. Sometimes they don't have much symptoms. They might not have much dyspnea. Maybe their dyspnea may be present, but it's really with a lot of exertion. The other thing that's really interesting is what about all that hypotension? This is what's really crazy. So they have this super high left ventricular end diastolic volume because they're accumulating tons of blood now because they're dilating their ventricles. Because of that, if you have a high left ventricular end diastolic volume, you have lots of preload. If you have lots of preload, you have lots of stroke volume. If you have lots of stroke volume, you have higher amounts of cardiac output. And in these patients, they tend to have hyperdynamic hearts, where they're literally squeezing tons of blood out of their left ventricle because they already have so much preload because of the aortic regurg. The blood's constantly circulating back to the left ventricle during diastole. So in this situation, it reduces their degree of hypotension or their degree of shock. And so they actually have hyperdynamic hearts. Hyperdynamic hearts, where their ejection fractions are actually much higher than like 60-65% generally to maintain a good cardiac output. So that's some of the things to be thinking about is they develop these hyperdynamic types of hearts and they reduce their pulmonary edema via this type of remodeling mechanism. And so really, in chronic AFib, they're relatively asymptomatic. Just like in mitral regurg, in chronic mitral regurg, they're relatively asymptomatic. They may have nonspecific symptoms like maybe a little bit of fatigue, maybe a little bit of dyspnea on exertion, but nothing spectacular that's going to point them out as, oh, that's aortic regurg. It's when they decompensate, whenever they actually have their contractility down. So in other words, their left ventricle starts dilating so much over time that they can't tolerate these high volumes that are being in the ventricles consistently, that the contractility starts going down. And if the contractility starts going down, stroke volume starts going down. And then you start seeing, again, worsening pulmonary edema and worsening cardiac output. Let's talk about that now. So, for decompensated chronic aortic regurg, we're at that situation now where you have high left ventricular end diastolic volumes, right? So you have these high left ventricular end diastolic volumes. And generally what this is supposed to do is it's supposed to increase your stroke volume. And that's supposed to increase your cardiac output. That was what we were doing in chronic aortic regurg. Now, in chronic aortic regurg, they start to have heart failure progression. And if they start to have heart failure progression, what starts actually occurring here is there happens to be a reduction in the contractility. The strength of their myocardium starts getting weaker and weaker. If you reduce contractility, you reduce stroke volume. And if you reduce stroke volume, you reduce cardiac output. And so what may actually start happening here is even though you have this high left ventricular end diastolic volume, but you have this progression in your heart failure, you're trying to maintain a high stroke volume, but your contractility drops, so you can't push all of that volume out. If you can't push all of that volume out, your cardiac output may not be truly good, and this actually may start leading to symptoms of potentially hypotension. That's one thing. So this kind of sounds like acute aortic regurg. It kind of is. It just may not be as intense to the point of cardiogenic shock. The other thing is if you reduce your stroke volume, that means that you keep more blood in the heart, right? And so again, if there's a lower stroke volume, you're going to again continue to increase your left ventricular end diastolic volume. And if you can't get that blood out, guess where it's going to go? It's going to lead to a backflow because you can't get it out of the heart. It's not leaving. And if it backflows into the left atrium, that'll backflow into the pulmonary circulation and lead to pulmonary edema. That'll worsen. So the whole concept here that you want to remember is they can have chronic aortic regurgitation, but if they start developing heart failure and progression of their heart failure to the point where their contractility starts to reduce, that's the key thing here, that will reduce their stroke volume and reduce their cardiac output, potentially putting them on the side of hypotension. But the big thing is if they have a reduction in the stroke volume, they are not getting volume out of their heart. So their volume in the heart is rising more than it usually is, and that's going to cause backflow into the left atrium, backflow into the pulmonary circulation, and worsen their pulmonary edema. That is the key thing to remember here. In decompensated chronic aortic regurg, it kind of looks like acute aortic regurg, because in a way it is. All right, so we have the patient with aortic regurgitation. We talked about acute, we talked about chronic, and we even talked about decompensated. The next thing that you guys need to remember, which is a huge differentiation factor for aortic regurgitation, is that particularly in chronic aortic regurgitation, there seems to be this situation where they have very, very wide pulse pressure. So we gotta understand what the heck pulse pressure is. So pulse pressure is basically you're taking the systolic, so we'll put PP as pulse pressure. It's going to be the systolic blood pressure minus the diastolic blood pressure. So here's what's really interesting in these patients. In patients who have aortic regurgitation, they have these really, really high, really high left ventricular end diastolic volumes. Those are pretty high because they're just constantly accumulating blood that's coming from the atria and shooting back down from the aorta. Okay, so that's how we're kind of getting this really massive left ventricular end diastolic volume. When you have left ventricular end diastolic volumes, that causes these massive increases in stroke volume. And so when they have these really high stroke volumes, they are just squeezing tons and tons of blood out of the left ventricle into the aorta during systole. So their blood pressure during systole is usually massive. Honestly, it's probably somewhere like appropriately, like for example, to give you an example, let's say that the systolic blood pressure is like 200 millimeters of mercury. Now here's where it's interesting. When you push blood out of the ventricle and into the aorta is a pretty elastic vessel. So it'll take and kind of accommodate that pressure into it. So it'll start to stretch and distend, and then it recoils. And when it recoils, it's supposed to push the blood into all the other systemic vessels. But some of the blood generally backflows into the ascending aorta and towards the aortic valve. The job of the aortic valve during diastole is to prevent the backflow of blood into the left ventricle, but it's not doing that. And so every time the patient goes into diastole, the blood shoots back from the aorta into the left ventricle, and it drops their diastolic blood pressure pretty abruptly. And so they have like a diastolic blood pressure anywhere, particularly maybe if you had systolic over diastolic, it may be like 200 over 40. Which is insane, because when you compare that to what a normal person's is, that pulse pressure is insane. That's about 160 pulse pressure difference. But if we compare that to someone normally, normal blood pressure is somewhere around 120 over 80. So that's a huge difference in their pulse pressure. And it's because they have very high systolics and very low diastolic pressures. Now, with that being said, some of the findings that are really high yield for your exam can come from these very high pulse pressure or wide pulse pressure findings. And one of them that you definitely don't want to forget is what's called the water hammer pulse. So we call it the water hammer pulse, or sometimes it's referred to the Corrigan's pulse. And what happens is, usually the patient's pulses are bounding. They have very bounding pulses because their systolic blood pressure is crazy high. So if you were to palpate the radial artery, it would be slamming and bounding pulses. But then here's what would be very interesting. You would take their arm, if they had a water hammer pulse, you'd feel their radial pulse, it'd be bounding, bounding, bounding. You lift it up, and boom, you would have this drop in their actual collapsing of the vessel. And so we call that the water hammer pulse. It's this quick, sudden rise in blood pressure, that bounding pulse, followed by a quick drop and collapsing of the pressure. And so that's coming because as your left ventricle is squeezing blood out during systole, about 200, gets pushed into the aorta, and then from the aorta should go into the systemic vessels. As the aorta relaxes and recoils, it pushes blood back down into the left ventricle, and that blood column is going to get yanked back. And so it causes this quick drop in pressure. So again, you'd have the pressure, you pulse, rapid rise, and then rapid fall that is going to occur when you kind of lift their arm up. They call it the water hammer pulse. Same kind of concept can happen with the carotids. We just call it the Corrigan's pulse. Another one, which is somewhat pathognomonic, is called the Hill's sign. And the Hill's sign is actually where you take the lower extremity blood pressures. So you take the lower extremity blood pressures and you compare it to the proximal, the upper extremity blood pressures. And so you can use like the brachial artery pressure and the popliteal pressure. And when you take like the popliteal pressure, let's say lower extremity pressure, it is much greater than the upper extremity blood pressure. Particularly, sometimes the systolic blood pressure can be greater than 60 millimeters of mercury in difference. Okay, so that's one of the big things to be able to think about here as well. So one of the things to think about is they have the water hammer pulses, the rapid rise and fall within that radial pulse when lifting their arm. And then the Hill sign, which is their lower extremity pressures, like their popliteal pressure, can be greater than their brachial artery pressure, sometimes greater than about 60 millimeters of mercury. And these are somewhat pathognomonic. There's many other ones, de Rosier's, Trobe's, pistol shot, Mueller's, Quincke's pulsations. We'll have all of those listed down in a little document in the description box if you guys want to see those. But these tend to be the most important ones to remember that you may see on your exam. Okay, so wide pulse pressure, we understand acute, we understand a chronic, we understand decompensated chronic. The last thing is, what are some of the findings that you can see because of the left ventricle being so dilated? So in left ventricular hypertrophy, we had a very intense left ventricular heave and an S4 heart sound. In left ventricular dilation, these guys are really good at filling with blood during diastole. So they allow for rapid ventricular filling. So because they allow for rapid ventricular filling, they actually have a lot of blood flow that's running into the ventricles during diastole that causes turbulent flow. And that rapid ventricular filling can actually produce a very classic heart sound, which is called a S3 heart sound. And you can get that because of the rapid ventricular filling process, because they accommodate and allow for a lot of blood to come into them, which produces turbulent flow. The last thing is, because these ventricles have a very high left ventricular end diastolic volume, they're again having very high stroke volumes. And because of that, they have very intense pounding types of contractions. And whenever they do that, it causes these very intense thrusting that you can actually palpate at the point of maximal intensity. So when you look at their PMI, they may have a thrusting type of quality of their PMI. So they may have a thrusting point of maximal intensity. The other thing is that because their left ventricle is super dilated, not only will their PMI be thrusting and intensity on the chest wall when you're palpating it, but in addition to that, they also have a lateral displacement of their PMI. So in other words, usually imagine like the left ventricle is here. It's dilating. Now the apex is going to be more laterally displaced. So that's another thing to add on. So they can have an S3 heart sound, a thrusting PMI, and they can also have a laterally displaced point of maximal intensity. So it's not going to be near the fifth intercostal space midclavicular line. It might actually be further towards like the mid-axillary line in these patients. Okay, that's the big things I want you guys to remember for the aortic regurgitation. Now, let's go into the diagnosis of let's go into the diagnosis of aortic stenosis and aortic regurgitation. All right, so let's talk about the diagnosis. So aortic stenosis, we got to listen to that murmur, okay? We got to figure out what's going on with the patient. So we go ahead, we take our stethoscope, what do we hear? Well, the first thing that you need to know is aortic stenosis is at what point in time in the cardiac cycle? That's the first thing I got to know. So it's going to happen during systole, right? It's because the problem is that I got a stenotic aortic vessel. It does just a pesky old valve there that whenever the left ventricle contracts, it's having difficulty getting the blood through the actual stenotic valve during systole. So the question is S1 to S2 is during ventricular systole. S2 to S1 is during the period of ventricular diastole. So I would hear that between S1 and S2. Now, what's really interesting is that these kind of valves, so imagine here is like your normal kind of like valve position here. They're like this, right? These valves are really stenotic, and what happens is whenever you try to generate pressure to open them up, because you have these stenotic aortic valve, it actually causes them to kind of dome up like this. So here's kind of their orifice, they dome up a little bit. And that doming, going from this position to this position, creates a snap sound. So it creates like a pop, a little snap, or a click, actually I should say, more of like a click sound. So it produces more of a kind of a click sound actually. And so that clicking sound is determining of an ejection click. It's a really, really nasty calcified fibrotic valve. So whenever you hear a click, an ejection click, right after the period of S1, it's usually a pathological sign of some type of aortic stenosis. So we'll see this ejection click. So we'll put EC, ejection click. Then, here's the next thing that's interesting. So you have the ejection click. Once you have the ejection click, your left ventricle is going to go into complete contraction, and it's going to try to push large volumes of blood out of the ventricle. Whenever the blood is actually leaving the ventricle, within the first couple milliseconds of blood leaving the ventricle, there is a lot of blood leaving. So what happens is a lot of blood is going to be moving out through that small little opening. And that's going to cause the sounds of the murmur to be super intense and increase as we continue to go on throughout this process. So the intensity of the murmur increases as blood is leaving through that actual very stenotic valve. But over time, as blood is leaving the ventricle, less blood is going to be remaining in the ventricle. If less blood is remaining in the ventricle towards the end of systole, that means less blood is going to be moving through or across that valve. That means the intensity of the sound as you get towards the end of systole should start decreasing. So in the beginning of systole, it'll go up because tons of blood is flowing through. And then towards the mid-end part of systole, the intensity of the sound should go down because less blood is leaving. And so then it starts to look like this. And this kind of gives like this interesting type of pattern to it, where the sounds look like they're going up throughout the period of systole and then going down towards the end of systole. And so we call when the sounds are going up crescendo, and when it's going down, decrescendo. So in these patients, they have what's called a ejection click followed by a crescendo, decrescendo, systolic murmur. Now, the next question that you should be asking is not only do they have the ejection click with the crescendo, decrescendo pattern of the murmur as the blood is flowing through it, it increases in the early phases of systole and then decreases in intensity towards the later phases of systole. That's pretty obvious. It's just the process of blood leaving the ventricles. There's going to be less as the systolic process goes on. What's really important to remember is, where do I hear this sound? Where would it be best heard? It's usually best heard where the aortic valve is placed, and generally that's in the right upper sternal border. So right upper sternal border, which is like that second intercostal space, is generally going to be a good area to listen. And the other question is there anything that can actually increase the intensity of the murmur? Because that's what I really want to know. And really anything that increases the volume of blood that comes into the ventricle, I'm going to have more blood in the ventricle. When I contract the ventricle, I'm going to have a larger volume of blood and longer time that I have to push that blood out. That's going to intensify the murmur. So I can increase the intensity of the murmur with venous return mechanisms. I can also increase the intensity of the murmur, not just with the venous return mechanisms, but I can also do this if I have expiration. You know, when you expire, you push blood from the actual lungs into the left atrium. You get more blood in the left ventricle, more blood to push out of the left ventricle. And so again, in these situations, not only would it happen with increased venous return, but it also could happen with expiration. And then the other thing to think about is, could afterload affect this? So afterload obviously will determine like the amount of blood that's leaving the ventricle. And so that kind of determines my stroke volume, right? So if I have some change in afterload, could that potentially change the intensity? Let's think about it. If I'm trying to pump blood out of my left ventricle and into the aorta, if the afterload is low, then I'll be able to pump more blood out, right? If the afterload is low, I'll be able to pump a ton of blood out of the left ventricle and into the aorta, and that'll be more sounds that'll be vicious as it moves across that area. And so potentially I could increase the intensity with a reduction in afterload. All right, so that's the basic concept. And again, it would be the exact opposite. If we wanted to decrease the intensity of the murmur, we would have less venous return. It would be during inspiration, and we would increase the patient's afterload, having them do like hand grip maneuvers, right? Okay, the other thing that I want you guys to do is actually take a little quick second to listen to this aortic stenotic murmur. Let's go ahead and take a listen to that real quick. All right, so we took a listen to that aortic stenotic murmur. Now what I want us to do is actually want to move on to the next test. Is EKG going to be helpful? Not really, so you don't have to remember all this stuff, but it's okay, we're going to go over it. Next thing, is a chest x-ray going to be helpful? Not really, it's not going to help me, but we'll go over it. What's the real important test that I need to know? The echo. That's the gold standard test, and we'll talk about what's important in diagnosing it, and then finally we'll also talk about what things determine the severity of it, which determines our management. Okay, EKG, what could it tell me? The big thing I really want you guys to take away from this one is it can tell you that you have left ventricular hypertrophy. That's really all I want you to know. A very thick left ventricle, so because you have that intense left ventricular hypertrophy, when you look at their actual R waves, their R waves are going to be super, super large within V5 to V6, and then their S waves are going to be super large in V1 to V3. And obviously there's different types of criteria that you can utilize to determine this. One of the common ones is, for example, you could take the R wave in V5, add up the height of it, and then add that to the height of the S wave in, like, for example, V3. And if that's greater than or equal to 35 millimeters, that's technically indicative or diagnostic of left ventricular hypertrophy. So there's different ways that you can do that, but again, you'll see very high peaking R waves in V4 to V6 and deeper S waves in V1 to V3. Those are something to think about as well. Okay, chest x-ray, will it tell me much? Not really. It may show some left ventricular hypertrophy. That's pretty much it. Could it show me some pulmonary edema? It could, but there's not really going to be something significant about this. Again, you may potentially see some pulmonary edema, and you may particularly see some left ventricular enlargement on the heart there. But really, it's not going to be anything special. So what I want you to know is you'll have a patient with a murmur, ejection click, crescendo decrescendo murmur, heard at the right upper sternal border, second intercostal space, increased intensity with expiration, venous return, and decreasing afterload. Then we can get the EKG, not helpful. Chest x-ray, not helpful. What do I really need? I need that echo, baby. So let's talk about the echo. All right, so the echo is definitely going to be the most important test that you need for a patient with any kind of valvular heart disease, really. But we can easily diagnose it, right? So with aortic stenosis, we definitely want to take a look at the aorta, right around that actual area of the outflow tract. And what we're looking for is we're looking for some thick, kind of fibrotic stenotic AV valve. Aortic valve. So we're looking for a very thick, fibrotic, stenotic aortic valve. That's one thing. The second thing is, what we're looking for is we really want to see how small is the orifice by which the blood is supposed to be going from the left ventricle into the aorta. Because that's really going to tell me what I need to know. I want to know how small that area is, because if I can determine the area, I can determine what the velocity is, I can determine what the pressure gradient is, and then there's some other things I can check too, like the ejection fraction, which tells me if there's dysfunction of the left ventricle, which is a concerning sign. Okay, so first thing I want to look at is I'm going to go a little bit out of order here. I want to look at the aortic valve area, the surface area. So really kind of telling me the area of that actual orifice, that opening of the aortic valve. Generally, what we want to not see is an aortic valve area less than 1 centimeter squared. So whenever it's getting to particularly less than 1.5, you can say less than 1. But generally, when this is getting to less than 1 centimeter squared, that is really severe. And that is a concerning finding. So the closer we're getting to 1 or less, the more severe the aortic stenosis. Now, if the aortic valve surface area is really small, that's a tiny area that I got to push a ton of blood through. I got to push blood through a tiny area. The velocity that I'm going to be pushing that blood through that area is going to be insane. So I'm going to have some very high jet velocities. So if you would actually calculate their jet velocities, particularly they can get up to greater than or equal to 0.4. They can get greater than or equal to 4 meters per second. Okay, so they can get greater than or equal to 4 meters per second. What else can be happening with these patients? Not only could they have high jet velocities, low aortic valve surface areas, but the mean pressure gradients can be really high too. The pressure gradients can be pretty crazy. So now I got to think, again, my left ventricle is going to be exerting tons of pressure to try to be able to push blood through that small little surface area. And so because of that, the pressure gradients will be very high, sometimes greater than or equal to 40 millimeters of mercury in these patients. Okay, so when they have high beam pressure gradients, low aortic valve areas, high jet velocities, these are all findings of severe aortic stenosis. But what's really interesting with aortic stenosis is their ejection fraction. We really, in these patients, their ventricles really have to be kind of like hyperdynamic and working really hard. If at any point in time the ejection fraction drops to less than 55%, we consider that actually like left ventricular dysfunction and not a good sign. So whenever we see the left ventricular ejection fraction that's hovering less than 55%, this is a severe finding. And we really want to start considering some more intense management in these patients, okay? So we heard the murmur, we checked the echo, we're looking for small surface area, high jet velocities through that small surface area, high pressures through that small surface area. And what happens is over time, if the left ventricle has to hypertrophy, it gets weak, it can't maintain this constant pressure that it has to continue to work at, it'll get weak. If the ejection fraction drops, that's a bad prognostic sign and they can go downhill quickly. And so whenever the EF gets less than 55%, we start to get concerned. All right, so let's talk about the diagnostics of aortic regurgitation. So we got a patient, we're taking a listen, we're going in, get our cool stethoscope, we're gonna listen to the heart. What are we gonna hear? Or the first thing, we think they have an aortic regurg murmur. All right, sounds blowing in quality. That's always the terminology, right? But you wanna know exactly at what time in the cardiac cycle would this be occurring. Well, let's think about it. Aortic regurgitation, the blood is just smashing back from the aorta into the left ventricle when the left ventricle is supposed to be filling. That's diastole. So diastole is between S2 to S1, right? That's the period of ventricular diastole. And then S1 to S2 is the period of ventricular systole. So it'd be between S2 to S1. Now, what's really interesting with this type of murmur is that whenever this murmur begins, it actually causes the blood to really flood quickly within the early phase. So there's going to be a quick, so let's do this in a nice color here to make it all look pretty, is right at the onset of ventricular diastole, right when the actual aortic semilunar valve and the pulmonary semilunar valve are supposed to snap shut. The aortic semilunar valve decides to misbehave and actually allow for blood to flood back into the left ventricle at the onset of the left ventricular diastole. When that happens, blood is going to shoot through quickly in the early parts of the diastole. And so it's going to be the loudest during the early phases of diastole. But as we continue down towards the end of diastole, the intensity will decrease in intensity because less blood is going to be moving across that aortic semilunar valve during the later phases of diastole. So you get kind of this diastolic decrescendo murmur. So again, this is going to be a diastolic decrescendo murmur. There's a decreasing intensity as you go farther into the diastolic period. It's loudest in the early part of diastole and then softest, almost not present in the late phases of diastole as less blood is flowing across that regurgitant or damaged aortic valve. So in this situation, it would be a diastolic decrescendo murmur. And again, when you hear this murmur, it's usually very blowing and insanely loud in quality, okay? The other thing when you have this murmur is you want to know where would you be listening for it. So generally you'd be listening towards, again, that right upper sternal border, which is like that second intercostal space. The other thing is it tends to radiate. So in this murmur, you may actually have some type of radiation. And when it actually does radiate, it tends to radiate from the right upper sternal border to the left upper sternal border. And so it actually may radiate in that direction. Whereas in aortic stenosis, we didn't actually mention this, but again, we'll cover this more in the heart sounds and heart murmurs lecture, but it actually does radiate. In aortic stenosis, it radiates particularly from the right upper sternal border into the carotids, okay? But in this one, aortic regurgitation, it would actually radiate to the left upper sternal border. The other thing is what can change the intensity of the murmur? What would actually make this murmur worse? Things that could actually increase the intensity of the murmur would be, again, having more volume in the left ventricle, pushing more blood into the aorta, and then more blood flooding back down. So anything that increases the volume on this side of the heart? What would increase volume on the left side of the heart? Well, it would either be increase in preload, return of blood, and high afterload. And so we can increase the intensity of the murmur in a couple different ways. One is we increase venous return, so squatting, passive leg raises. Expiration always increases the intensity of left-sided murmurs, and then having a higher afterload. If you have a higher afterload, you're going to have more volume inside of the left ventricle, and so whenever you push the blood out, a lot of it's going to flood back through. So higher afterloads will also potentially increase the intensity of the murmur. And then the same situation, if you want to decrease the intensity of the murmur, have decreased venous return, inspiration, and decrease the afterload. And that'll have more stroke volume that'll actually be there. And so if you have more stroke volume, you have less volume within the left ventricle, so less blood to be able to push out. So those are the things that I want you guys to remember here. Okay, now we've talked about that. Let's go ahead and have a listen to what the actual aortic regurgitation murmur sounds like. All right, so we took a listen to that murmur. Now what I want to do is I want to cover the next things. Is an EKG going to be absolutely necessary for this patient? No, not really. It's not really going to be super helpful, to be honest with you. It may show some random types of things. So for example, you may pick up that they have potentially like a little bit of left ventricular hypertrophy. Unlikely though. It may, because you have a lot of like distension and dilation, it may stretch the bundle branches. And particularly it may kind of stretch that left bundle branch. And whenever you stretch the left bundle branch, it actually can cause dysfunction of left bundle branch and sometimes actually cause a block. So there may or may not be some type of left bundle branch block. Also, because it's super dilated, there's maybe a decrease in the mean QRS vector. And sometimes it actually can cause a left axis deviation. So there may be left axis deviation as well. Are these things at all helpful in diagnosing a patient with aortic regurgitation? No. But again, they're tests to think about in these patients. A chest x-ray, is it going to help me? Not really, but what could I potentially find? I may find some pulmonary edema. So there could be some findings of pulmonary edema. And because the left ventricle is gargantuous, there may be some cardiomegaly because of that insane amount of left ventricular dilation. But again, is it going to be helpful to get the EKG? No. Is it going to be helpful to get the echo? Get the chest x-ray? No. What's the absolute necessary test that we need? We need the echo. So let's go ahead and take a look at the echo. All right, so we need the echo for this patient. So let's take a look at this patient's hot air balloon of a heart here that, up and away this heart goes. It's so dang big. But that's what happens in these patients who have aortic regurgitation. They got these massive left ventricular dilation to accommodate these super large volumes. Now, when we take a look at the echo here, we obviously know the straightforward thing that's going to happen in these patients is when they have aortic regurgitation, they're going to have this massive regurgitation jet that's going to be pushing blood from the aorta into the left ventricle during what phase? During diastole. What we want to know is, of this regurgitation, what is the fraction? What is the width? And then at the actual level of the aortic valve, the orifice, what's the actual area of that orifice? Then I want to know, okay, how darn big is the left ventricular diameter? Because as it gets bigger, dysfunction can start occurring. And then the last thing is, how good is it actually able to contract? Because at any point it starts not becoming hyperdynamic anymore, I'm going to get concerned. So what are the things I want to know? Regurgitation fraction, I want to know the percentage. And so generally, any time that's greater than or equal to 50%, you should be concerned. Okay, that's a large volume of regurgitation to come back. Regurg orifice, this little space here. So when the regurg orifice is larger, obviously you should be very concerned, to the point where if it's greater than or equal to 0.3 centimeters squared, that is a pretty big orifice, and that's a high risk of progressing into severe aortic regurgitation. The next thing is the left ventricular insystolic diameter. So basically, it's dilating how much volume of blood is sitting in the ventricles right before they go into systole. Because what this tells me is that the left ventricle is either super dilated and accumulating tons of blood, and on top of that, it might not be doing as well as maintaining a good contractility and an EF. If this is getting greater than or equal to 50 millimeters, that is a concerning sign. And the last thing here is that generally, as you have higher end diastolic volumes, you have higher stroke volumes, which keeps your cardiac output up. So in these patients with aortic regurgitation, they have hyperdynamic hearts. If at any point in time their ejection fraction starts dropping to the point where it's like less than 55%. So if the ejection fraction is less than 55%, this is significant of terrible left ventricular dysfunction. And these patients need to start potentially getting ready to go get some type of intervention. All right? So big thing, when we get the echo, and we're gonna take a look at here one in a second, we wanna look at, again, regurgitation jet with a high regurgitation fraction, a big aortic valve orifice where the regurgitation is occurring, a very large and dilated left ventricle, and when the ejection fraction is declining to where it's less than 55%, these are terrible signs and very, very poorly prognostic signs of aortic regurgitation. They'll need more intense management. So let's go ahead and take a look at the echo. All right, so when we talk about the treatment of aortic stenosis, right, we're gonna start with that one. You can start with some, particularly for the mild, moderate aortic stenosis where they're not super symptomatic really. They have the diagnosis, maybe they get some little bit of, syncope, angina, dyspnea on exertion. You've diagnosed them on echo that they definitely had some form of aortic stenosis, but the categorization of the aortic valve surface areas, their jet velocities, their mean pressure gradients are, they're not too bad, but they're definitely within like that mild to moderate category. But they don't need any kind of like immediate surgical intervention. In those situations, we can try to medically manage these patients. It's not super successful and it's not super helpful because we actually have to restrict more than we actually give medications. So we should actually know what kind of things we should actually restrict or prevent the patients from doing that could worsen their scenario. So if they have mild to moderate aortic stenosis, and you should recommend this for all patients, regardless of their severity, but what kind of things we should avoid. In these patients, remember I told you, think about vasodilators. You know vasodilators or venodilators, anything like that? What they do is they drop your afterload, right? So they can drop your afterload, or if they venodilate, you get reduction of preload into the left side of the heart. Well, right side of the heart and then eventually the left side of the heart. So think about that. Giving any kind of drug, like a venodilator, could reduce your preload. If you reduce your preload, you reduce your actual diastolic filling process, you reduce your stroke volume, reduce your cardiac output, and then if you reduce your cardiac output, you reduce the amount of blood that you're being able to deliver to the brain, to the heart, and that's a problematic issue. So in these patients, we should definitely avoid any kind of venodilator. So for example, drugs that you probably would want to stay away from in these patients would be things like nitroglycerin. Those would definitely be some things to stay away from. In the same aspect, it might even be beneficial to potentially avoid other things that can drop the contractility of the heart. What are some things that can actually drop the contractility of the heart, which if you drop the contractility, you drop the stroke volume, you drop the cardiac output. Beta blockers, calcium channel blockers. So another thing to probably consider is avoiding certain things like beta blockers and avoiding things like calcium channel blockers in these patients. Okay? And again, the reason why you're avoiding the venodilators is because this will reduce preload and then that will reduce stroke volume. If you give beta blockers or calcium channel blockers, what these are going to do is they can do a couple different things. They can decrease heart rate and they can potentially decrease contractility, and combination of these things can reduce your stroke volume. And then you're not perfusing particular organs like your heart or your brain, and that can worsen some of those particular symptoms. What are some other things to potentially consider? Obviously, excessive amounts of exertion. So don't get dehydrated and avoid excessive exertion because during those exertional time periods, you vasodilate your vessels. When you vasodilate your vessels, what do? If you vasodilate them, you actually drop your systemic vascular resistance. If you drop your systemic vascular resistance and you have a fixed cardiac output, you're not going to allow for perfusion to the brain. You can cause syncope. And so these are things to potentially avoid, avoid excessive exertion. Okay? And then don't get dehydrated as well. And then the other thing is be cautious. Because these patients may have certain other issues, one of the things to be considerate of is be very cautious with vasodilators, so arterial vasodilators. So I would be very cautious with those. And the only reason why is that you want to make sure that if you're being cautious with vasodilators, particularly the arterial side, this would be things like hydralazine, isosorbide dinitrate, nitroprusside, ACE inhibitors, ARBs, nifedipine, things of that nature. What they can do is, with this kind of situation, is they can drop your systemic vascular resistance and drop your mean arterial pressure. And that could be a problem because that could reduce perfusion to the heart, that could reduce perfusion to the brain, and again, problematic issues could ensue. So these are things to be very, very careful of in these patients, which is avoiding dehydration, really avoiding venodilators, vasodilators, beta blockers, calcium channel blockers, and excessive exertion. Those are things to be very, very, very thoughtful of in these patients. All right. One of the other things that we want to consider is, all right, we've tried to avoid a lot of particular medications. At what point do we need to do therapeutic interventions to prevent the progression of aortic stenosis into full-blown heart failure and, potential complications that we can see from this, such as terrible angina, terrible syncope, terrible dyspnea? What are the things that we can do? So you can consider something called a percutaneous balloon valvuloplasty. And all this is you're taking like a catheter, you're threading it up through like one of the actual femoral arteries and into this area. What you do is you actually take this catheter and you put like a catheter has a balloon over it, over the area of the aortic valve where it's suprastenotic, and then you inflate the balloon. And when you inflate the balloon, it's supposed to stretch open that actual stenotic valve, creating a larger larger aortic valve surface area so more blood can run through it. So you would do this particularly, what the indications are, is for patients who have aortic valve stenosis without significant calcifications. Because once there's like lots and lots of calcifications, it's unlikely that they will benefit from a percutaneous balloon valvuloplasty. So it's really beneficial for those patients with aortic valve stenosis without a lot of significant calcifications. You can give this a shot. Now, preferably, when would we say, okay, we can try percutaneous balloon valvuloplasty. Here's the indications. We do it. It fails. Or the patient has lots of calcification. So one of the reasons we would say contraindicated is they have lots and lots of calcifications. We may try to do something like a valve replacement. The second thing is that's not a contraindication, but maybe an indication to do a valve replacement is you fail the percutaneous balloon valvuloplasty. This may be an indication for valve replacement. What are some other indications for valve replacement? So it's maybe a patient who has lots of calcifications so they can't get the percutaneous balloon valvuloplasty, or they've gotten it, they failed, they need a valve replacement. What are the real significant indications though to go straight to a valve replacement? The real indications for this is if the patient has any kinds of symptoms. So there's a couple indications. One is if they are symptomatic. Okay, so they have symptoms. These are any kinds of syncope on exertion, angina on exertion, dyspnea on exertion, any of those things, and they have the categorization of severe aortic stenosis. And they have severe aortic stenosis. How do we categorize the aortic stenosis and severity? That's why I told you we need to know the echo. They have to have high, jet velocities. What was the number if you really want to remember it? The jet velocities. It was somewhere near the area of greater than or equal to 4 meters per second. They have to have low aortic valve areas. What was the number? Less than 1 centimeter squared. They also need to have high mean pressure gradients. So high mean pressure gradients, particularly greater than or equal to 40 millimeters mercury. And then what else? Maybe if their ejection fraction is low. So sometimes we also say if their ejection fraction is less than 55%. These may be indications. So if they're symptomatic and they have any of these things, this is considered to be an indication for getting a valve replacement. So what are some other indications for why someone should get these valve replacements? Another one is particularly is even if the patient is asymptomatic, right? So the patient has no symptoms. So if the patient has no symptoms, but they have, again, an ejection fraction of less than 55%. This is an indication. But you can also say not only could it be this, but you can add on there if they have no symptoms and an ejection fraction less than 55%, and maybe on top of that, they also need to get cardiac surgery for some other particular reason. So if they need to get cardiac surgery for some other particular reason, that might also be a particular indication. So these are particular reasons why someone would get a valve replacement. So again, they either have symptomatic issues and severe categorization of aortic stenosis, which is categorized by the jet velocity, the aortic valve area, the mean pressure gradient, and the ejection fraction. Or if they're not symptomatic, but their ejection fraction is less than 55% and they need a cardiac surgery for some other underlying reason that's not related to the valve problem, that would be an indication for a valve replacement. Now, when you do a valve replacement of the aortic valve, you can do it two ways. It can be done surgical, or it can be done via what's called a trans-aortic valve replacement. So in other words, what we do surgically is we open them up. We'll go in and we'll actually replace the valve that way. The other one is the trans-aortic. So we'll actually take like a catheter, maybe run it through the femoral artery all the way up until we get into the aorta and near where the aortic valve is and replace it that way. So particularly surgical would be for those patients who maybe, they're a lower risk and they have some other complications that they were trying to do. So this would be a good example. Like for example, someone needs like a CABG. So they need to get a coronary artery bypass graft. This would be a good indication to do a surgical because you have to open them up. Or if they have any kind of like very low surgical risk, because the surgical process is going to be way more intense. So if they're a lower surgical risk category, they would probably be better for this one. But the TAVR would be better for patients who have high surgical risk, at risk for lots of complications from getting the surgical procedure. So we would prefer the TAVR in high surgical risk patients who would not be good candidates for the surgical replacement of the valve. So this is the basic things that I want you guys to know. So a patient who has aortic stenosis, we can try to do medical therapy, but really it's just avoiding a lot of stuff. You can try the percutaneous balloon valvuloplasty, particularly if they don't have a lot of calcifications. A lot of the time they do. So it's not going to work. If you try it though and it fails, you can try the valve replacement. Other reasons you could get the valve replacement is they're severe aortic stenosis by those categories on the echo, and they're symptomatic, or they're asymptomatic and they have a low ejection fraction, less than 55, and they need a cardiac surgery for another reason. If they get it, there's two ways you can do it. You can open them up, be preferred if you're opening them up for another reason like a CABG, and they have very low surgical risk kinds of complications. Or you can do a TAVR where you go in transcatheter-wise, which is better for the patients who are at higher risk of surgical complications. Now that we've talked about that, let's move on to something else. When you replace these valves, okay, you replace the aortic valve, we can use two types of valves. We can use mechanical valves or bioprosthetic valves. Why is this significant? The significance of this is that the mechanical valves, they are very thrombotic. So they have high risk of forming thrombi on them. So because of that, if you're going to give someone a mechanical aortic valve that has a high risk of thrombus formation, they're probably going to need lifelong anticoagulation with warfarin for the rest of their life. So because of that, if they need lifelong anticoagulation, this would be better for patients who are younger. You want to know why? Younger because this valve lasts a super long time. So it's actually going to be worth them getting it. The second thing is younger patients generally a little bit healthier, right? And the second thing is we want these patients to have a very low risk of bleeding. Okay? So in these patients, if you're going to put them on anticoagulation, they now have a high risk of bleeding. You would prefer this to be in a patient who has very low risk of bleeding, so generally younger. Second thing is they're probably on anticoagulation for some other reason, like atrial fibrillation. So if that's the case, they're going to benefit better from this type of valve, the mechanical heart valves. So that's the big thing to remember. Lasts long, but high thrombogenic rate, needs lifelong anticoagulation. Best patients to get is the ones who have a low bleeding risk or are young, because it's going to give them a long period of time. Generally like less than 60, 65 years of age. For the bioprosthetic valves, these don't have a very high thrombogenic rate. They still can form thrombi, so they may need anticoagulation, but it might only be for like 3 months. Then after that, you don't need to continue it. What's really important is that this valve don't last very long. It gives you about 10 years. So about 10 years of length. So for this one, we would prefer this because this would be good for a patient who's like super old and they're already on the way out. That sounds terrible, but it's true. In those patients who have a very low life expectancy, this may be better. So we prefer this in older patients. And also because there's not much anticoagulation, they're at lower risk of bleeding. So this would be better for a patient who has a high risk of bleeding and can't get a mechanical valve. So it's really straightforward, right? The only other thing to remember is that patients with the bioprosthetic valves are at a higher risk of infective endocarditis of that prosthetic valve. So sometimes they require some prophylaxis with amoxicillin if they get any kind of like dental procedures because they're at high risk for infection, because the bacteria can get in through the actual dental areas into the blood and then travel to the heart and cause infections. That's a big thing to remember. So we have a patient with aortic stenosis, avoid a lot of crap. Try the percutaneous balloon valvuloplasty, but if they have calcifications, it's not going to really benefit them. So we go to the valve replacement. We know the indications. Once we replace the valve, we have to pick which valve is best for the patient based upon a lot of their risk factors and their age. After we've done that, we now have hit home the aortic stenosis. Let's talk about aortic regurg, which is a little bit more intense. All right, so we're going to talk about aortic regurg, how we're going to treat this one. So again, we got to remember there's two different types. Technically, there's acute and chronic, and then technically there's decompensated chronic aortic regurg. But when someone has decompensated chronic aortic regurg, we kind of might treat them like a acute aortic regurg. But again, you get the point because we talked about that a lot previously. But let's kind of keep it simple. Let's talk about how we treat acute and how we treat chronic. All right, so acute aortic regurg, this is again, what were the particular ones that I told you to think about? This is like the infective endocarditis. So this is the patient who has like infective endocarditis and they cause like a destructive lesion of that valve. It also could be due to an aortic dissection. And I said it could be due to like an acute rheumatic attack, like rheumatic heart disease. All right, so those are some of the things to think about. If they have this acute aortic regurgitation, where now this valve is all jacked up, what can happen? Well, you guys remember we said that this is going to cause patients to become super hypotensive, right? Because what's happening is we're just flooding tons of blood back into the left ventricle. So it's flooding all that blood into the left ventricle. And if we're flooding all that blood into the left ventricle, less blood is actually being technically pushed out of the left ventricle into the aorta, because everything we push into the left ventricle, a certain fraction of that pumps back down into the left ventricle. So there is going to be a reduction in their actual stroke volume and a reduction in their cardiac output and potentially hypotension. We said that was one of the complications. When someone is super hypotensive, we want to address that hypotension. And so what we need to do is get the heart to squeeze harder. And so we want to get it to squeeze harder. If we needed to do that, we use different types of medications called inotropes, things like dobutamine, things like milrinone, because they're going to squeeze the heart and increase the cardiac output. The other thing we want to do is we want to try to get the vessels out here to dilate. Because if we dilate them, we reduce the afterload and make it easier for the blood to go from the left ventricle into the aorta, right? So we want to use something called afterload reducers. And this may be drugs like hydralazine. This may be drugs like nitroprusside. This may be things like ACE inhibitors, ARBs, things of that nature. So we want to give afterload reducers. So this will increase contractility. This will increase your actual stroke volume by reducing the afterload. The other thing is that you do not, for the love of goodness, you put a person on an intra-aortic balloon pump, you will kill them. So there is no intra-aortic balloon pump. It is contraindicated in these patients, okay? You do not want to do this. You can definitely cause them to, likely die. So in these patients, you want to temporize them, their hypotension with inotropes, afterload reducers, stay away from the intra-aortic balloon pump, and get them to that valve replacement as soon as possible. The other thing is that because their left ventricle is accumulating so much blood and it's having less blood that's technically being ejected out, if your left ventricular end diastolic volume is higher and you don't dilate and accommodate that volume, your pressure goes up. If the pressure goes up, it makes it harder for blood to go from the left atrium to the left ventricle. Left atrial pressures go up. Backflows into the pulmonary circulation leads to pulmonary edema. That pulmonary edema is a son of a gun because it can cause intense hypoxia and shortness of breath. We can treat that with BiPAP to push some of the actual fluid out of the interstitial spaces. We can give things like diuretics as well to pull some of that fluid from the interstitial spaces as well. Once we've treated the hypotension and the pulmonary edema, again, get them to that valve replacement stat. All right, so for a patient with chronic aortic regurgitation, how are we treating them? Well, obviously we treat them, heart failure treatment. So obviously with these patients, you're going to be treating any kind of heart failure, the pulmonary edema that they may have. So if we're treating heart failure, obviously there's a lot of different things that we could do that. We're trying to treat the symptoms. So obviously we could do fluid restriction, so fluid and sodium restriction. We could try to do diuretics, things like furosemide to pull off any excess fluid. You obviously could try to reduce a lot of the remodeling with ACE inhibitors, ARBs, right? And then sometimes we can even say beta blockers may be beneficial. So these are a lot of the kind of like your hallmark treatments for patients with aortic regurgitation who potentially are progressing to heart failure. So that's a lot of things that you could do. You could even give a lot of other afterload reducers such as hydralazine, nifedipine, isosorbide dinitrate, a lot of things like that. But generally that's what you're going to do for chronic aortic regurg that may have some symptoms of heart failure and progression towards like a little bit worsening stages of heart failure. What's really key to know is when do I kind of give up on the heart failure stuff and say, okay, it's time to go ahead and go straight to the valve replacement. Generally, whenever a patient's ejection fraction in the aortic regurg is dropping, that's a pretty good indication. So that's one definite thing I would say is if you start seeing a patient who has aortic regurgitation and their ejection fraction is dropping, regardless if they're symptomatic or asymptomatic, it doesn't matter. Usually patients with aortic regurg should be hyperdynamic. So at any point in time that EF drops less than 55%, regardless of symptoms, that's an indication to get an aortic valve replacement. So again, if the ejection fraction is less than 55%, regardless of symptoms, so plus or minus symptoms, it doesn't matter. This is definitely an indication because should not be that low. Generally, they should be hyperdynamic. That's one reason. Now, if the patient also is particularly not just an ejection fraction less than 55%, but let's say that they have an ejection fraction less than 55% and they have no symptoms and they have an underlying reason that they need to get like a cardiac surgery. They got to get like a CABG. That would be another indication. So for other reasons is patients who actually are asymptomatic and they need to get a surgery, a cardiac surgery for another underlying reason besides aortic regurgitation. So sometimes it could be asymptomatic plus they need to get a cardiac surgery, right? They need to get a cardiac surgery for another reason. And on top of that, this patient has ejection fraction less than 55%. So we could say if the patient has an ejection fraction less than 55% and they have symptoms or not symptoms, doesn't matter, they need to get that replacement. If they're asymptomatic and have ejection fraction less than 55% and they have a cardiac surgery that they need to get for another particular reason other than the aortic valve is the issue, that would be an indication. The last one is if the patient has any severe symptoms, like severe characteristics. They could be, again, asymptomatic. So generally at this point, they would have to be symptomatic and they would have severe aortic regurgitation. And the way that we categorize these patients' severe aortic regurgitation is we look at, was their left ventricular insystolic diameter really, really big? Remember we said it was like greater than 50, or like greater than or equal to 50 millimeters, telling me that their gargantuous ventricles are super volume overloaded. Do they have very high regurgitation fractions? Is there high, particularly what's called the ejection regurgitation orifice? So remember we said that the regurgitation fractions, if they're greater than or equal to 50%, that's a really bad aortic regurgitation. Or if their ejection regurgitation orifice was greater than or equal to 0.3 centimeters squared, that was a really bad aortic regurgitation. These are some of the indications. So if a patient is symptomatic and they have severe aortic regurgitation by these echo findings, that would be an indication to get a valve replacement. If they're asymptomatic, they have an EF of less than 55%, and they need a cardiac surgery for another underlying reason that's not due to the aortic valve, that would be an indication to get a valve replacement. So we got acute aortic regurg, boom, to get them stabilized, get them a valve replacement. Chronic, treat their underlying heart failure. Fluid restrict, sodium restrict, diuretics, beta blockers, ACE inhibitors, ARBs, hydralazine, isosorbide dinitrate for afterload reduction. If they start having ejection fractions dropping less than 55% and they're asymptomatic, boom, they get the surgery. If they also need a cardiac surgery for another underlying reason, even better, boom, they get the surgery. If they are symptomatic and they have characteristics on their echo of severe aortic stenosis, boom, they get the surgery. So they have a left ventricular insystolic diameter greater than or equal to 50 millimeters, a regurgitation fraction greater than 50%, or their ejection regurgitation orifice is greater than or equal to 0.3 centimeters squared. Boom, they get that valve replacement. Then when we replace that valve, remember I told you in aortic stenosis, well, particularly in the mitral valve diseases, like if someone has we can do transcatheter, we can do like a transaortic replacement of the valve, particularly in like a patient who has various different issues, like particularly aortic stenosis, we can do a transaortic valve replacement. In patients with aortic regurgitation, there's actually not much literature to support a aortic valve replacement for aortic regurgitation. We particularly go straight surgical for these patients. So again, there's still exploration and studies being done for the transaortic valvular replacement and aortic regurg, but primarily if someone needs to get an aortic valve replacement, they get the surgical. They get opened up and they either get a mechanical valve based upon the criteria we talked about, or the bioprosthetic valve based upon the criteria that we talked about. Engineers, we'd uncovered the aortic stenosis and the aortic regurgitation. I hope it made sense. I hope that you enjoyed it. And as always, until next time.